Welcome to Evidence-Based Cardiology Talks. This is the deep dive where we really unpack the latest, most relevant publications in contemporary cardiology for you.
Great to be here. So today we're tackling a pretty significant piece of research, and it digs into the connection between, well, the amount of ischemia and whether getting procedures early on to fix that flow, revascularization, whether doing that early actually helps prevent major problems like death or heart attack.
Yeah, and this is such a hot topic, isn't it? I mean, cardiology is constantly debating this. When do we step in with a procedure versus just sticking with medication?
Exactly. The ischemia trial really stirred the pot on that one.
It certainly did.
But this new study gives us a fresh look, and with a lot of data, we're talking over 40,000 patients across 12 centers internationally. So it's big, and it's contemporary too. The data runs from 2009 right up to 2021.
That range is important, covering a period where treatments have definitely evolved.
For sure. So the core question, the real mission for us today, based on this study, is where's the tipping point?
Yeah.
At what level of ischemia does early revascularization seem to actually cut the risk of death or MI?
And crucially, did that tipping point stay the same over that whole study period?
Right. Or did it shift?
Yeah.
And did it look different for, say, men versus women or other patient groups?
Okay, let's get into it. How did they actually measure this?
Well, first, the methodology.
Oh.
It was retrospective, meaning they looked back at existing patient data.
Okay, so not a randomized trial like ischemia.
Correct. They focused on patients who'd had myocardial perfusion imaging MPI using SPECT scans. That's how they quantified the ischemia, put a percentage on it.
Got it. And early revascularization.
They defined that as getting a procedure like a stent or bypass within 90 days of that scan.
Makes sense. But since it wasn't randomized, how did they account for the fact that patients getting procedures might be different from those managed medically from the start? Maybe sicker or maybe healthier in some ways?
Good point. They used a statistical technique called a propensity score.
Ah, propensity matching or scoring.
Right.
Basically trying to level the playing field statistically.
Exactly. It helps adjust for those baseline differences between the groups, so you can try and isolate the effect of the treatment itself.
And after doing all that adjustment, what did they find overall? What was the main headline?
The key takeaway, the big number, was that early revascularization seemed to be linked with a lower risk of death or MI, but specifically in patients who had more than 9.0% myocardial ischemia.
So 9.0%. That's the threshold they identified overall.
That's the main threshold, yeah. They mentioned the upper confidence limit was around 11.2%, just for context.
And importantly, they found a significant interaction, right? Meaning benefit really depended on how much ischemia there was.
Yes, precisely. The p-value for that interaction was less than 0.001, so a strong statistical signal that the amount of ischemia really mattered for whether early revascularization helped.
Okay, so more ischemia, potentially more benefit from intervening early. That feels intuitive.
It does, but here's where it gets really interesting and maybe more complex for clinical practice. They didn't just find one number. They looked at when the patients were studied.
Ah, the time trend. What did they see there?
Well, this is quite striking. The threshold for benefit actually went up over time.
Really? How much?
So for patients scanned more recently, say 2014 to 2021, the benefit was seen only above 14.0% ischemia.
14%? Wow.
Yeah. But if you look at the earlier group, 2009 to 2014, the threshold was lower benefit was seen above 6.5% ischemia.
That's a huge difference, over double. Any thoughts on why such a big shift?
The likely culprit seems to be improvements in medical therapy.
Makes sense. Guideline-directed medical therapy has gotten much better.
Totally. Think about, high-intensity statins being used more routinely, better antiplatelet strategies, newer drugs coming online.
All those things likely mean we're managing stable coronary disease more effectively with pills alone now.
Exactly. Which could mean that for patients with, say, 8% ischemia today, the added benefit of an early procedure might be less than it was a decade ago because the medical therapy is doing a better job.
So the bar for needing an intervention for a given amount of ischemia seems to have gotten higher. That has real implications for how you approach these patients.
It really does. Now, they also slice the data by sex.
Mm-hmm.
Any differences there?
Yes, there were slight differences. The potential benefit threshold was a bit higher in women, over 10.0% ischemia.
About 10% for women. And for men?
For men, it was slightly lower, over 8.6%.
Interesting. Not a massive gap, but a difference nonetheless.
Yeah.
Do the authors speculate why?
They did mention looking back at the ischemia trial, where women tended to have more symptoms,
Right.
and maybe potentially received more aggressive medical therapy because of those symptoms, if something similar was happening in this registry population.
Then maybe women needed a slightly higher ischemia burden before the additional benefit of revascularization really showed up compared to men, assuming their medical therapy was already quite optimized.
That's one possible interpretation, yes. It definitely raises questions about potential differences in management or perhaps underlying biology.
Okay, what about prior CAD? Did
Yeah.
having a history of heart disease change things?
It did. Another layer of complexity here. For patients without prior CAD, the benefit threshold was lower, around 7.6% ischemia.
So 7.6% if it's their first rodeo, so to speak.
Right. But for those with a history of prior CAD, maybe they'd had a previous MI or bypass or stent. The threshold was higher. Benefit was seen above 11.4% ischemia for them.
Okay, so the patient's history matters quite a bit too.
It seems to. Perhaps suggesting that in patients who've already got established, treated disease, you might need a larger area of new or worsening ischemia to justify another early intervention over just optimizing their meds again.
So if we pull all this together, the overall 9% threshold, the fact it's gone up over time, the differences between men and women, and between those with and without prior CAD, what's the big picture message?
I think the really crucial takeaway is that relying on one single ischemia number, like saying anyone over X% needs revascularization, is probably not the right way to go anymore. It's too simplistic.
Yeah, this study really hammers that home.
It strongly suggests the benefit depends on when the patient is being assessed, reflecting changes in medical therapy.
Their sex, their previous heart history.
Exactly. It really pushes us towards, more personalized decision-making. We need to consider the whole patient, not just that MPI percentage.
Yeah, that term, personalized decision-making, feels more relevant than ever in light of these findings. But we should also touch on the limitations, right? Every study has them.
Absolutely essential. First off, as we said, it's retrospective, looking back at data. So we see associations, but we can't definitively prove cause and effect like in our randomized trial. The revascularization is associated with better outcomes above certain thresholds, but we can't be 100% sure it caused them.
Good point. Anything else?
Well, they didn't have super detailed data on, say, changes in medications after the MPI scan. Maybe some people in the medical therapy group later got their meds intensified or stopped taking them. That could muddy the waters a bit.
True, that post-scan management detail is often missing in registries.
And the primary outcome included all-cause mortality, not just cardiac death. While dying from any cause is obviously critical, it means factors unrelated to the heart disease or the procedure could influence that outcome.
Right, makes sense. Okay, so let's try and wrap this up. What are the absolute key points you want our listeners to take away from this deep dive?
Okay, point one. Early revascularization does seem linked to better outcomes, less death or MI, but primarily in patients with a higher ischemia burden.
But point two, that higher burden isn't a fixed number. It seems to have increased over the last decade or so, probably because our medications have gotten so much better.
Precisely. Point three. The threshold also seems to vary a bit, slightly different for men versus women, and notably different depending on whether the patient has a history of prior coronary disease.
So the clear message is, move beyond a single ischemia percentage.
Definitely. We need a more nuanced approach. You have to integrate that ischemia percentage with the timing, the patient's characteristics, their history, everything.
It's about synthesizing more information for a truly personalized plan.
Exactly. It highlights this dynamic interplay between how bad the ischemia is, how good our drugs are now, and who the patient sitting in front of you actually is.
So a final thought for you, our listener. Given this evolving picture, with medical therapy getting stronger, how does this study influence your thinking? When you see a patient with, say, 8% or 12% or 15% ischemia, how do these findings shape that conversation about revascularization versus meds? And crucially, what other factors, beyond just that percentage, are you weighing most heavily to make the best call for that specific patient? Something to really mull over. Thanks for joining us.